Hello, this is Dr. David Greene, CEO of the Florida Pain Network. Today's topic is the basics of sciatica. Sciatica occurs when one of the nerve roots of the sciatic nerve is pinched. Now, the sciatic nerve is actually a combination of three nerve roots. See here, L4, L5, and S1 comes out of the spine, meets up, and then runs down the back of the leg as the sciatic nerve. 1 to 2% of the population suffers from sciatica at any one point in time. Most commonly, it occurs from either a herniated disc or spinal stenosis. There can also be other reasons, such as a nerve root irritation due to degenerative discs or bulging discs, possibly a tumor, and then a problem after the nerve roots, meaning a problem after these things come together with something going on down here. Now, how does it occur? Well, when a disc degenerates, the outer layer can tear and part of the inner gelatinous area can squeeze out, okay, and then it can pinch on a nerve root. This in and of itself does not cause pain. It may cause weakness, but what it does is when it causes pain, it's the inflammation that sparks up that causes the pain with sciatica going down the nerve root. Now, if you have disc degeneration, where you don't have, let's say it stops here, if you have disc degeneration and a tear in this outer part but not the herniation, it can still cause sciatica because of the chemical inflammation that area can cause and irritate the adjacent nerve root. Symptoms are going to vary. It could be a burning sensation, electrical sensation, a pins and needles sensation, possibly some numbness or some motor weakness. Rarely, a patient may have incontinence. That becomes a surgical emergency. How is it diagnosed? Well, typically it's history and physical exam. Here you see a doctor doing what's called a straight leg raise test. That pulls tension on the nerve root. If it's being pinched, it will really, really hurt. And then if you bend the knee, that takes tension off the nerve root. So that's called a straight leg raise test. An MRI, for example, can be very indicative. This is a cross-section showing a huge disc herniation coming back into the canal. If necessary, a nerve conduction study can be performed. And if you can't make heads or tails of it, a diagnostic injection can be done around the suspected nerve root irritation and see if that relieves it. Sciatica treatment, limited bed rest has been shown to be best, no more than 48 hours. Medications should start with anti-inflammatories, Tylenol, muscle relaxers. Neuropathic medications can help, like Neurontin or Lyrica. And then opiates for a short-term manner can be very, very helpful. Physical therapy, chiropractic treatment can both be helpful. A TENS unit, such as you see here, is about the size of an iPod. These little foam pads go on the skin and emit slight electrical impulses for pain relief. Acupuncture can help along with a treatment called spinal decompression therapy. Interventional treatments may consist of trigger point injections, which are subcutaneous injections in the muscle tissue to relieve weakness and spasms of the muscles. And then epidural injections, like you see here, place the steroid medication right around the nerve root where it's getting pinched. Not into the nerve root, but right around it. All right? And that has over 75% good to excellent results. It can be done as a series, and then it can be repeated every few months, the whole series. Well, what are the outcomes? Over 95% of sciatica patients are successfully treated without surgery. There was a landmark study done close to 10 years ago that showed the one-year outcome between operative and non-operative patients is identical between those who who underwent surgery for sciatica. The absolute indication for sciatica surgery is cauda equina, which is a huge compression of the end of the spinal cord area, which can lead to bowel and bladder problems that can become permanent if it's not treated emergently. If you start having muscle weakness, that becomes what's known as a relative indication. You can watch that for a few weeks, even for a few months, but at a certain point you watch it too long, and if it doesn't get better, then the person could have surgery. It may never get better. So that's why it becomes a relative indication. Surgery should be considered sooner. And then electively, if it's just for a pain issue, 6 to 8 weeks of failed non-operative treatment, then the person can start to consider surgery. The top non-operative pain management in Florida is through the Florida Pain Network. There are many clinics throughout the state participating, accepting over 50 insurances and providing over 25 different treatment options with the board-certified award-winning doctors. For the Tampa area, visit us online today at painmanagementtampa.com and then call us for more information and scheduling at 813-666-4399. I'm Dr. David Greene with the Florida Pain Network. Your pain stops here.